Thank you.
Dr.
Okay,
Bharti, you
go
want
ahead,
to add?
Ramamurthy. We'll talk later.
Thank you, Dr. Puredra, for this, including me in this wonderful course of yours. It's always a pleasure to be with you. I'm to cover the challenging situations with phakic intraocular lenses. First, let me run through the normal way that I do a phakic intraocular lens, which is very well covered by Partha. I do not dilate my eyes simply because I am wary of the knives touching the anterior capsule. It has happened occasionally in my cataract surgery. In those cases, you just include it in the capsular rhexis. But here you have the undilated pupil. You can see me making the incisions at 3 o'clock and 9 o'clock. I'm seated temporarily. And even now, I've just used a little bit of saline to firm up the eye. And it's a 3 millimeter incision that I make. After that, I introduce a combination of phenylephrine and xylocaine, and you can see the pupil very nicely dilating. Usually in these young patients, not a problem. Then, as was mentioned, I'm using sodium hyaluronate, which again gives a viscodilatation, and that's the intraocular lens going in. Actually, it's hardly an edited video. It just takes about a couple of minutes, and you have to position the lenses, which have all been very nicely covered, always injected in front of the iris, then position the lens behind. And the most important thing, the other variation that I do is, I don't go in with a irrigation aspiration cannula at all. Long back, it was proven that it is during that step when surgically induced cataract can occur. All I do is to depress my central incision as well as the side ports. And once the entire bolus of viscoelastic comes out, that is sodium hyaluronate, and you have clear fluid coming out, then that tells me that the entire viscoelastic is out. So no irrigation aspiration, no dilatation, and that's intraocular lens. And of course, when you have a toric intraocular lens, I go ahead and use a digital overlay to position my lenses. And as you can see, it takes about 2.5 minutes. And usually, as I mentioned, I do the second eye immediately. This is, of course, the ideal situation where the lens is well centered. You have a central hole, and then you have about a 500 micron, which is equivalent to the corneal thickness. And but then you do come across challenges. Whenever you get a lens which is not positioned in the optimal manner, then it's always a good idea to rotate it. As you can see over here, that's the toric overlay. I don't introduce any viscoelastic at all, but just going with the irrigation cannula, and that was the lens position that the lens had rotated. And I do it very often, even within a week's time. And usually, if the spherical equivalent of the residual error is 0, then repositioning of these lenses does work. And this is something that you owe it to yourself and your patients. Don't get compromised results. And our uptake of toric phakic intraocular lenses is almost 75%, because even small amounts of residual astigmatism does lead to unsatisfaction in these patients. It was already mentioned, just to show you these things. This is 120 microns of vault. 500 is supposed to be the normal, 250 to 750 is the range. I think this is just 85 microns. These are patients of mine whom I have been following up almost for 4 years now. I've been using these slides for some time now. And there's no evidence of cataract, though it is said to, and it's a good idea to have a 500 micron vault. And that's the reason I do not do the surgery on the same day. Even with these lower vaults, as far as the anterior capsule is clear, and the patient is quite happy with the visual outcome, you do not have to do anything. But in case you have ended up with a cataract like this, which does occur once in a while, whenever you're, these are all videos which are run at twice the speed. Staining is extremely important even before you introduce any viscoelastic, because there's often an anterior subcapsular fibrosis. Then just you can hold one end of the lens, one of the haptics. Then with a hand-over-hand maneuver, you can remove the entire lens. All that you need is a 2.8 millimeter incision for this, and it can be done even through a 2.4 millimeter. Then subsequently, I dilate the pupil was already dilated. As you can see, getting a good capsular rhexis is extremely important in these cases. Once you do that, it's usually a soft lens, and you can go ahead and do the cataract surgery as is routine. As far as the intraocular lens power calculation is concerned, there is no change, because it is the thin optics of the lens do not cause any delay either in the ultrasound or in the laser interference biometry. This is a high volt, as you can see here. More than 750 is a cause of concern. But even a 1000 micron volt, if the angles are open, if the angles are getting pigmented, the angles are getting zipped up, then it's definitely an indication for removing the, exchanging the lens. But as far as the angles are open, the pressure is under control, patient is coming for a regular checkup. I have a few patients doing this over the years. You can let the lens be there. Iatrogenic keratoconus, as you can see, as far as the cone is well centered, which you judge on the posterior float, when the most of the float is in the central 3 millimeters, at least more than 50%. Then it's you can see this patient has a minus 3.5 with minus 5.5 diopters, and this is a post-intact scenario where already a CXL intact has been done for a iatrogenic keratoconus patient, not just a keratoconus patient. And subsequently, I go ahead and implant a toric intraocular lens. And this is usually I do after about 6 months to a year after stabilization of the refractive error as well as the corneal topography is there. When the patient is improving its spectacle correction, implanting a toric phakic intraocular lens is going to help. If he or she requires rigid contact lens for rehabilitation, putting in a phakic intraocular lens is not a good idea. This is another situation that was an intact scenario. Here it's a keratoconus, and you can see minus 4.5 with minus 4 diopters. We did a topo-guided PRK for this patient, and you can see that the cone is much better regularized. What you have is a with the rule astigmatism over here. So this patient is now is ready for getting a phakic intraocular lens. This is again pre-CXL intact. You can see minus 13 with minus 1.5, and the vision is not improving. But once I place the intacts and CXL, actually more of the astigmatism get revealed, but you have an extremely well-centered cone, and the patient is improving to 6.9 with a myopic astigmatism, obviously a good candidate for a phakic intraocular lens. But there is an area that you need to address in these keratoconus cases, because the chamber must be fallaciously deep in the central area of the cone. And if you go by just the central reading, you might end up implanting a lens which is slightly larger than what should go in. So basically what we do routinely is to, when you do handle these cases of keratoconus, is to go for one size or two sizes lower. You can also take multiple measurements of the anterior chamber depth, but then it's a little confusing. So as a rule, we just go for two steps lower. As you can see over here, post-keratoconus, you have a optic capture, and there's a fairly deep, fairly high wall that we have. So what we had to do in this case is to go ahead and replace this lens with a lens which is two sizes lower. So that's a toric intraocular lens which is there. Basically, the exchange of the lens is not much different than what I showed during the cataract surgery. Only thing is, bring the one haptic of the lens into the anterior chamber. Then with a hand-over-hand maneuver, you get the lens out. There's no change in the power. Only thing is the lens that was introduced was two sizes lower. This was before we understood the sizing of these lenses in case of keratoconus. Now that we reduce the lens by one size for ICLs because it comes at 0.5 millimeters, two sizes for IPCL because it comes in jumps of 0.25 millimeter, we find that this is not something that we encounter, and patients are quite happy. And of course, there are situations of dull penetrating keratoplasty, where an excellent surgery, the results are, refractive results are compromised because of the high astigmatism. In these cases, you can always use a toric phakic intraocular lens, cognizant of the fact that the endothelium, especially if it's a PK case, is somewhat tenuous, and your surgery has to be as gentle as possible so that you do not damage the endothelium in any way. This is a great way to rehabilitate significant refractive errors. Once the cornea is stable, the sutures are out, and there is a significant refractive error that's left over. Both myself and Partha started in 2004 with phakic iris clip lenses. This was I gave that up simply because there was a progressive endothelial cell loss. This was a lady with both eyes operated 1 week apart, who had an excellent refractive outcome, but her endothelial cell count had dropped down to less than 1,500. She was very unwilling, but I somehow convinced her to have an exchange, but she was not willing to compromise on the excellent refractive outcome. So basically what I'm doing here is to create a 6 millimeter incision and get the phakic intraocular lens, or the iris clip lens out, and then subsequently place shorten the make the incision a little shorter, and then subsequently introduce the phakic intraocular lens into the eye. And both the eyes were done 1 week apart. I have been having about a 5-year follow-up of this patient, and the endothelial cell count has stopped dropping. I think the posterior chamber is the right place the phakic intraocular lens to be in. A case of nystagmus, very keen on phakic intraocular lens. Here again, because of high myopia, I don't want to give a peribulbar anesthesia. Once you have an instrument inside, like either a spatula or even if you have the injector inside, then you can get hold of the movement of the eye and go ahead and implant these eyes, though I would not suggest this to the beginners. And this is a unique case. I thought posterior synechia, very keen on phakic intraocular lens. I thought this is going to simply come off when I use an iris spatula, and this is just a posterior synechia. But when once I introduced the lens, fortunately it was not a toric lens, it was a non-toric lens, and I tried to release this posterior synechia, I realized that it was very significantly adherent, and if I had used excessive force, maybe I would have created a poor anterior capsular rent. So I decided to just leave it alone and see what the refractive outcome is. Obviously not something that would be described in the books, and this is what we saw post-operatively. But fortunately, the patient was quite happy with the clinical, with the refractive results, so we left the eye as such. And this is a case where I had an initial toric ICL, and the patient almost had 6.5 diopters of astigmatism, and then wanted the residual astigmatism also to be corrected. The cornea, you can do a laser vision correction, but here the cornea was not fit for that. Very keen on outcome, so I made a custom-made toric IPCL made, and then exchanged a toric ICL with a toric IPCL. Mind you, I believe both the IPCL and ICL, for that matter, the other variants of the Indian lenses are also quite good. Our uptake is almost like 50% each, essentially depending upon the patient's ability to pay for it. This is, I think, the final video, ICL in a brittle cornea. As you can see, a very routine case. I thought it's a walk in the park case, but as soon as I started introducing the lens, the corneal incision just gave up. As you can see, the chamber is shallowing, viscoelastic is flowing out, and I have no control over what's going on. I went ahead, just introduced the lens into the anterior chamber, decided to suture up, and then not a very elegant surgery, but somehow managed to get the lens behind the iris. But then I realized that even the side port incisions were giving way. So it was essentially a brittle cornea that we had, and because of the good refractive outcome that the patient had, insisted on surgery in the second eye a week later, which I performed. Actually, the patient was posted for both eyes, but after this happened in the first eye, I decided not to do the second eye. And exactly the same process followed in the second eye, but bilaterally implanted. The patient was quite happy with the outcome. This is what you see. I had put the patient on cycloplegic for a significant length of time, and there was pigment dispersal, but the eye did settle down. Thank you so much for your kind attention.
Thank